Now, 1 foot off center.
And now it's all gonna blow your mind.
Rick Maddison here, 1 foot off center, and I'm here with my good friend Scott Lanigan, Jeff Cox, Ron Mattiussi, and gentlemen, I play a high level of pickleball. Okay, and as such, when I play, I get to meet all walks of life, and one of them, a very good fellow, very good pickleballer, and he's a GP, and he said he was talking about the fact that 44% of GPs in the province of BC are slated to retire in the next 5 years. And that, when I anecdotally talk to a number of families in the neighborhood, as I move through the community, I'm like, that seems like a lot of people can't even get a doctor. So I'm wondering for the group, because we keep getting pushes to build density, but shouldn't we also be really looking at this critical nature of healthcare for the Okanagan, which is also a catchment area for a lot of communities. As we all know, emergency rooms are shut down in various communities, and it just feels like we're on the knife's edge for healthcare. And we solve most things here around this table. But Jeff Cox, you have a background in healthcare. You know of this beast. Do you care to weigh in? Are we on a knife's edge for healthcare?
I'm not a doctor, that's for sure. We are, and I said this. I don't think our healthcare system is broken. I think when you have serious needs, I think our healthcare system can deliver. I've witnessed that firsthand. I think if you need a knee replacement, you got a long haul ahead of you, and that can get fatiguing. We have some challenges, but like the other things we've talked about, there are solutions. But this is complicated. You have federal funding that's pretty much driven down in the province. We've had governments that have threatened to cut it depending on what we do. We've had 10 years of NDP that have really moved to big healthcare, which is to centralize everything, make everybody a government employee, and again there are 27 countries that run universal healthcare programs very similar to ours, and there is data that is produced every year that shows the metrics of those countries and how they perform, and we are at the top of funding. So we sit, depending on, again, it's not like there's just a figure, but we sit 1, 2, 3, 4 out of 27, and our deliverables fall mostly at the back end, so 20 to 27. The odd one is about 15. That's you can't say that we're doing okay. That's broken. So but how do you fix it? And this is the conversation nobody's wanted to have in Canada. And the reality is, when I hear that, what needs to change is not coverage, because as soon as you say private healthcare, people lose their mind, right? Somebody right now just heard me say that, oh, that guy just loses his mind.
Yeah, must be a conservative.
Yeah. So here's the deal. We should, and I'm a firm believer as a Canadian, in universal healthcare, more than we have today, because a lot of our healthcare has already gone private. I think there is a place for us to have a better universal healthcare system. But universal healthcare means that the government is the insurer. It does not mean that the government employee needs to mop the floors at a hospital. And again, people say, well, then you're going to have everybody that's got money going to a hospital, and they're going to have their own room, and they're going to get served shrimp, and everybody else is going to get left. It's like, no. So here's the deal: like, reasonable and customary charges can be applied. Again, I said this. You get on a plane because it's comfortable. We're not flying on government planes. We have a standard that exists in multiple lines in our country to say this is the bar. If the bar is not met, the doors close. Again, you go to the U.S., a lot of Blue Cross organizations are what we call not-for-profit. So not to be mistaken, because they have salaries and they pay big salaries and they have money. But there are other ways to do it. The challenge to date has been no one is willing to talk about it. And then we move into these places like we are in British Columbia, where we've had a socialist government that's also said, beyond the fact they're not willing to talk about it, they're going to move more towards big government, and everybody's government employee, and everybody's going to meet their mandate. And unless we're willing to have at least a conversation about it, we're not going to change.
It feels like I had, speaking of different surgeries you can do, there was
No thanks.
I don't even know where your head went, but it was fun. But I did hear that there was a time when you could get hip or knee surgery through a clinic, and it was basically paid for by the province, but they kept it very hush-hush just because they're dealing with overflow. They were trying to get ahead of the wait list and everything else. And it just seemed like that method that worked very well. I mean, a lot of people got bumped up the list, and they were like, wow, you're calling me now? I thought I'd be waiting a year or 2 years. So there's different aspects, but for some reason there seems to be, again, no appetite for the NDP to even acknowledge these discussions exist. Ron, at the city level, again, and I'm not sure if you had a role in this, but the 6th floor of KGH is empty, and it just needs staffing, and and I've heard that if funding started tomorrow, it would still be 3 years out. But I know that we need that space, and it seems like, can the city push any kind of action on that front?
Cities are always pushing. Like West Kelowna's asked for a critical bid. Right now, if the bridge is down, you don't get to hospital even though you're right there. So communities are always asking. And one of the problems that they've had, and I think this is here, but it's a case in Alberta as well, somebody got the bright idea to create massive hospital regions, which was really a way to cut costs and have somebody else take the blame, right? So I mean, this happens right across the board. So in this area, like the hospital region, interior health, the regional districts actually contribute fund through what's called a regional health district, but it's really the regional district putting on a different hat. And so they do fund facilities. So part of that funding went to, I'm pretty sure it was went to actually fund that extra floor so it could be built more economically at the time the rest of the building.
I see.
So you had an empty floor that, in fairness, was never intended that it was going to be immediately used. I mean, I think Recreation suggested pickleball up there, but they said the ball makes too much noise when it hits.
I'd be in.
So I think we have that, but I think a fundamental problem is not looking at those because it's sacred. I mean, from Tommy Douglas on down, it's sacred, and I think part of the problem we have is, I think lots of people, the Romano report years ago for Paul Martin, lots of people have said that. There are lots of models, but everybody's afraid. And I think it comes down to trust. True. I think Pierre Poilievre tomorrow could say, let's look at healthcare. And let's have this, and some people go, a conservative talking about healthcare. He just wants an American, and that would be it. Right, that would be it. And now the Liberals would have something he's going to privatize medicine. It's going to be like the States. So I think we have to get back to a position where our leadership, regardless of party, maybe have to take a leadership role, maybe like we're doing now with the United States, and take a step back and say, how do we work together? Because nothing that you say I disagree with, and yet we're probably not in the same political areas. And yet pretty reasonably said, take a look at it.
We agree almost all the time.
All the time. That's the funny part. But, it's privatized now.
Yeah.
Like, I had just had my eyes done on, cataract, but there was 3 types of cataract surgery you could have. I'm sure it's the same in other areas. There's a lot of privatization that's in there now that I don't think it takes pressure off the hospitals. And if people are willing to I don't consider myself Elon Musk, but if I can afford a little more money and get something a little faster, whatever, then that's fine. As long as everyone gets gets health care in a timely manner, I think our system. If you have something serious, they deal with it. Doesn't matter who you are. Mm-hmm. So I think the fundamentals are there. I agree with you, Jeff. It's the money's there. How do you structure it? And I'm seeing models and. That are being put in place now where municipalities are hiring doctors. They're becoming municipal. Why? Because they wouldn't go there. For the doctor, it's a benefit because they get a paycheck without all the worries of running their own corporation that they had. So they work on patients in the morning, they visit, and then they have to worry about their accountant all night. So we're seeing that's a model. Try it. Try it. Why don't we look at those things? But yeah, I think the impact, anything that impacts a community ultimately becomes a problem in the community. Ultimately, The city is a sidebar player, but a player.
Mr. Scott, what?
Yeah, I think I would say, Rick, I think often it depends where you live. Like in the Fraser Health region, there's 6 hospitals within 20 minutes, right?
Yeah.
And then you're going to live in Rock Creek. Well, you chose to live in Rock Creek, right? And now you're going to have to travel if you need some health care. And so I think, different people would have different perspectives in our province based on where they're living, obviously. But, I think it's interesting when it comes to practically speaking about individuals getting care and their particular experience with that. I know in Sweden, for example, that they have rules in their ICUs that only a certain age they'll accept into ICU. So north of 75, 80, they say, hey, it's quality of life. And I think I say that because I think a lot of what we think about when we come to a hospital is just, can I get care no matter what age? And I don't think we always talk about quality of life, especially for an elderly. I think we talked about boomers before and the different impact on that thing. Well, that has an impact directly on our hospitals province-wide. And I was talking to a physician this week, and he said, often they'll have conversations with families who, bring an elderly parent or grandparent in there, and they're in their 90s, and they have never talked about end-of-life scenarios. They don't talk about it. And rather, they're like, hey, we need to do everything we can to keep this person alive, when in reality, their quality of life does not kind of indicate that there's going to be an extension to their life longer. And so our hospitals are an acute care system. So we have people in our beds right now that actually need long-term care or palliative care, but we don't have the space to do it. We don't have the facilities to do it. And so here we are, we're clogging up our hospital, when in reality, we actually have more space than we think. And rather than thinking larger and what are some solutions, we can't actually service in the best way possible because we don't have options. So the doctors are doing their best, the nurses are doing their best, but in reality, their hands are tied. And, the other thing is, I think from a doctor perspective, looping back to your pickleball buddy, is that I think, we have a number of individuals coming here who have accreditation in different parts of the world, Philippines, South Africa, Nigeria, whatever. And maybe their accreditations are the same level of training, but it's so difficult for them to become or recred or challenge the different protocols. So they have to re-educate. And I think there needs to be some creative solutions again. Well, maybe some of those people, maybe they're a surgeon in their home country, which they couldn't be here, but maybe they could be a surgeon's assistant here, and they could use some of those skill sets rather than just going into housekeeping. And I think there are some solutions that if we're creative and just maybe step back a little bit and go, hey, how can we actually, empower people rather than penalize people for not kind of building. And I agree with you, Jeff. We need to have those standards, but maybe there's ways to actually think a bit differently so we can create some time and space.
It's amazing you've talked about. So she's rest in peace. My grandmother got a hip replacement at 84. She's 3 years past life expectancy today. From when she was born, she's about 22 years past life expectancy, and then lived another 18 months. And when she got out of the surgery and rehab, she didn't go for a run. Like, it's not like we were. And I love the woman. She was, but like, I remember saying, "This is insane. Why is my grandmother getting a hip replacement at 84?" Right. Just a couple of quick points were brought, and very, very great points. But Ron brought it up about some of the things that have gone that people may not be aware that have gone against us in the last 10 years. So you used to be able to pay for an MRI yourself and then take it to your doctor and say, hey, I know where I'm at. The NDP said, yeah, go ahead and pay for the MRI, but you're not going to change your place in line. So you're still going to be 200th, even though you have the MRI, because that would be considered, a private component to healthcare. And if the 199 people ahead of you can't afford to do it, we're not letting you go to the front. Again, ridiculous. So now, so somebody's willing to alleviate pressure on the system. We're not going to do that. The other big thing, when you started about attracting healthcare workers, and it was brought up about the municipal doctor, I probably agree with that in the sense that it's not unique to doctors or dentists, but they're not by nature business people. That's not what they do. Mm-hmm. Just like I'm not a doctor. Like they by nature are do their job and they do it well. They shouldn't be running businesses. It's not in their best interest. But further to that, we have taken away every possible advantage they had to run a business in the past 15 years. So we've stopped income splitting. And somebody will listen to that and say, oh, they're going to pay their fair share of taxes. That's a ridiculous statement. That we've stopped income splitting. We recently, it's been deferred, but we were going to change capital gains exemptions. Doctors were told 20 years ago, we are not going to pay you a pension. Instead of a pension, we will give you the ability to have a capital gains exemption when you sell your business, taken away. That list goes on and on and on. And when you add them all up, it becomes to a place where they start looking around going, this doesn't make a lot of sense to me. And so it makes sense that they would want to be employed by a municipality and say, give me my paycheck, let me get on with my life. And maybe that is the change that needs to happen.
Yeah, to me, it's mind-blowing. And, I think I mentioned before, I came in 95, and one of the reasons I came is the Plain government was getting rid of regional planning, things like that. And the deputy minister I was dealing with said, their biggest focus in 1995 was on healthcare because they knew it was going to eat up their whole provincial budget. Mm-hmm. And, and they said, we built schools for the baby boomers, we built universities for the baby boomers, now we're building hospitals for the baby boomers. And this is going to drain the provincial budgets. And the only thing I ever thought, that was 95, is like, he mustn't have shared that with anyone because it's a long time to have known that. and here we are, watch the demographics unfold. Yeah. And apologize to everyone in the health profession because I'm not in that world, but sitting on the outside looking in, what are those things that didn't take shape? I mean, what was it? We'll create a big IHA and they'll look after all the problems because we'll consolidate where we wash our clothes. I mean, those probably were what people thought were practical solutions, but on the medical side, you're not seeing a lot of innovation. Nurse practitioners. I grew up in Sault Ste. Marie, 1960. The steel workers opened a clinic, hired a doctor, same principal, hired their own doctor. They used nurse practitioners, 1960 Ontario, to actually do the front end work.
And we're still talking about it like it's innovative.
It's like innovative, exactly.
Like, hey, you know what? A nurse practitioner can give a prescription. Like, we should get on that. And you're right. It's like here we are.
So there was a fellow I had a long conversation with. He was in charge of the ICU at KGH and former director. And he said the choke point for any hospital is that acute care, that emergency room. Like he said, if that critical care is stacked, there is no place for those people to go. Like he says, if that is choked out and every bed is taken, that hospital is now in distress. It's paralyzed because you can't fit anymore, and you need a certain level of expertise to look after those people that need the care. So he was saying when COVID came around, he said it basically accelerated a whole bunch of people to retire and leave healthcare. Mm-hmm. And he says, we knew this train was coming. And he says, we had long meetings and strategy meetings about how the fact that this squeeze was coming. And he says, did we do much? Not really. And I think further to my GP friend, he says, Rick, GPs are going to be a thing of the past. They're going to be specialists, and there's going to be nurse practitioners. That's where we're heading. Wow. And that was, that's a GP saying that. So I don't know if that's innovation or just, we're getting into the brass tacks, and that's what we have to do. But I do feel like our community is a catchment, and so for a lot of communities, they rely on Kelowna especially to look after everything. A lot of people.
Yeah.
So I don't know what the answer is, but Jeff, and further to your grandmother, what's interesting is I did talk to a fellow, again, another pickleballer, who got a knee replaced.
Big social circle.
It's growing. I know pickleball has taken off, but he said he got bumped up a bit, and sorry for releasing this information, but he got bumped up because he was in better shape, and the doctor says, I know for a fact that you will be active 6 weeks after you get this knee replaced. You'll be moving again. And so I do feel like doctors are somehow navigating those lists a bit better and saying who has the best chance of utilizing this, because in some ways it's a big gift.
I mean, we could do an 8-part series on this. I mean, then you get into the business of it. Like, to say, to have the broad spectrum of nurses all represented by the same union makes no sense. Like, if you're a GI nurse versus a critical care nurse, those are very different jobs. If you do echocardiograms, that is a very different job. They've been bundled. Like, there are pieces to this. It goes back to what you said about paramedics. I talked to a paramedic in Calgary last week, and I said, hey, what union represents you? And she said, at one time, it was a small QP union because we were city employees. And she goes, and then we got massed together, and now we're in with 10,000 other healthcare workers, and we've become the wrench point. But we're not winning, and again, there are so many pieces to this that need to be unwound and probably put back together, because that list goes on, But it is important to reiterate. I think when push comes to shove and something is serious, I firmly believe our healthcare system is not broken, and I'm a huge fan of I believe Canadians should have access to healthcare no matter where you live or what your income is. But that doesn't mean we can't have conversations about private deliverables. Right. Mm-hmm. Those are two very different things that as soon as you say it, people say, oh, this guy's in American healthcare. Nope, not it at all. But
I agree with, currency is wait time in hospitals,
Right.
and that's the currency that goes. And actually, Kelowna has one of the best ER wait times in the province, and so that's a positive in our. So I agree with you, kind of practically speaking here, and I actually believe it's all going to be solved because the premier's wife is a physician. So I think it's probably all going to just trickle down eventually.
I think nothing like a crisis to finally get people off their ass as well. I mean, we're at this point where at some point in time they're going to. I mean, they saw it coming. But I shouldn't say it, but jokingly aside, the first rule of government: if you don't have to do anything, don't do anything. And I think as long as the system sort of worked, it sort of worked. Why would you raise alarm bells? Like, why would you shift funding away from? Alberta government, great conservative government. I thought, Peter Lougheed, one of the best premiers I'd ever lived under, but they created 10-bed hospitals in towns that they couldn't staff. Yeah. Mm-hmm. And they would probably admit it was economic development. Well, now you're using healthcare dollars for economic, shame on you. Mm-hmm. Shame on you, right? I mean, there are better solutions. So I think healthcare has been used that way too over the years, not blaming any one particular government, or whatever, but when are we going to start really looking at these problems as creative? Let's break some of those barriers. Let's stop the rhetoric. Let's just be practical. I mean, most people in Canada, I probably get a lot of letters for this, but I agree with you. I think there is an element of privatization. I come from a staunch NDP family background. I paid for my MRI because I had a problem and I wanted to know if it was serious. Yeah. I wasn't going to wait 6 months. I paid. Yep. Didn't break me. It was my birthday present.
You didn't jump in front of the line either.
Didn't jump in front of any
Still
line. Didn't hurt anybody. And I could say, yeah, well, that was fine. I don't think I put healthcare in crisis in BC because I did that. So anyways, I just think that, a lot of things are happening in the world right now that are pretty horrible and are pretty screwed up and are pretty bad. If there's a silver lining of all that is, I think it's also waking people up that we have to change the way we're doing things. We have to get away from the rhetoric. And I think in this case is, if you actually talk to people and say, would you accept this? Take out the rhetoric, take out the privatization. Mm-hmm. But would you pay for some of this stuff? I think most people say absolutely.
Oh, I think so. I think... when Dr. Michael Humer was running, I heard some of his campaign stuff, and he was talking about patient-centric, getting more attention paid to the, to the people that need it instead of these top-heavy. Further to your point, Jeff, and I think he mentioned one stat, and I'll get it wrong, but it was about how in Alberta they have 7 VPs of healthcare, and BC has 42. So.
It's
Go for it.
It's pretty close. So it's like we have it's 3-to-1 administrators. Is that So we have 3 administrators to every frontline worker.
Right.
Like that's like if that doesn't get you angry, I don't know what does. Right? Like it's like what?
Mm-hmm.
But I don't know how you can be at the lead of that of a crisis like we have in Canada with healthcare and say, this is working. What? You know what I mean? Like I don't get it.
Yeah.
That's what I don't get.
But I've never had a bad experience at KGH, and I mean that from the heart. I've never had a bad experience.
Yeah. No. When I first check in, they go, "What's your name?" I said, "Private," and my last name is Room.
Oh yes, we have a ward for you, Mr. Maddison.
It's the 6th floor. I would like to thank again Scott Lanigan, Jeff Cox from Mattiussi. I'm Rick Maddison. We're 1 foot off center. Thanks for watching. Thanks for listening.